So welcome to Raising Health. The news for 2024 is that BioEat's World is getting an upgrade. We're rebranding as Raising Health. And as our very first guest on Raising Health, it's my pleasure to welcome Sean Duffy, CEO and co-founder of Omada Health. So Sean, thank you so much for joining.
Yeah, Vijay, thank you. And thanks for allowing me to be the first. What an honor.
This starts with actually that email that you sent me, or I think it was actually maybe even a tweet that I saw, that Omada hit 1 million patients.
That's right. Yeah.
And so that was a huge deal. And I think that made us very sentimental about like all the whole path that you've been through and the path that we've been through together.
Oh, for sure. No, I mean, 1 million, we're really proud of it. I'm proud of the team. I think it's a lot of people. It's a big impact. And I think if you pull up, I think it is a statement on where digital health has come from and that it's possible. Admittedly, I feel two ways about it. I think the positives are, my gosh, it took, so many years of toil to even get to the couple of thousand. But then if you compare the 1 million to the task at hand of actually impacting epidemiology and really, doing what we need to do for the business, we haven't really made a dent yet. Kind of told our teams, let's celebrate for 30 seconds and let's go try to get it to 10, 20, 50 and beyond.
Well, you make a great point because 1 million is hitting scale, but in principle, you could get to tens, hundreds of millions and even beyond. Like, yep. How do you view the next steps? Like, how do you get to that type of scale?
Well, I think you're at 1 million. You're on strong foundations. As long as you're serving your members well and you're serving your customers well, it does become slightly easier because we're in a new state in digital health where it's a little bit more accepted. There's a little bit more trust. We now have published trials, data, et cetera. So we're staying hungry as possible. And I think it just shows that the space though has progressed a lot. It's still relatively nascent relative to having the impact that it can and will.
Yeah. Well, so before we get too far ahead of ourselves, actually, I'd love to take us back to the beginning.
Sure.
So to set the stage, I guess it's 2011, right?
That's right. Yep.
And when you started Omada, obviously there were 0 patients then. What did that 0 to 1 part of the startup look like? What was that like?
Yeah. So first, just I'm here in the in recent offices, kind of speaking with someone who probably is in the same camp, but I've always been pulled between technology and science in healthcare. Originally, I thought I had to choose. I had to pick, tech or healthcare. So after undergrad, even though I did my pre-med recs, I worked at Google for a couple of years. I went off to medical school. I was enrolled in Harvard's MD MBA. And then, through that came up with the idea for Omada. And really the key reflection was kind of a statement of where the market was at the time. I'd be with my tech friends from Google and like, oh my gosh, these like Fitbits, they're going to change healthcare. My medical school classmates were like, well, where's the level 1 evidence? What disease areas are you targeting? And so, the idea for Omada was to build a convergence company, one that didn't sacrifice on technology and design, but tried to do so in such a way where it earned the trust of the existing healthcare market. So that led to the business and 0 to 1. It was a journey. I mean, we were a little ahead of our times. I think we when we founded the company, the world kind of didn't know what to do with us.
So yeah, tell us more. Like you were a tech company, but you were also a healthcare company.
Yeah, no, and I mean, it's in the early days of Omada, for instance, you'd say hi to a health plan and say, I want to contract, as a provider, and like, okay, great. Well, where are your clinics? Like, we don't have any. Like, excuse me, where are your clinics? Like, no, we're a provider. We don't have offices. They're like, well, you can't contract with our network team.
It's like a hotel chain without hotels.
Yeah, exactly. And so to be honest, I mean, the last 10 years has been, that scene from Apollo 13 with like the square CO2 cartridge and round hole where you just try to like somehow pull it off with the parts on the ship before your oxygen depletes, which is your bank account, in startup language.
Yeah, well, and I made that analogy to the hotel company without hotels.
Yes,
yeah, exactly. Airbnb, and then there's
totally
fleets without cars and so on.
Yep.
So it makes sense in that 0 to 1 time. There was probably some surprises. I don't know if there's any notable surprises that makes sense to recount.
I quickly realized how hard it was to sell into enterprise healthcare. It was a surprise to me. Now it's not a surprise at all. And I'll kind of relay that to any tech founder. It's like the key thing was that it was not sexy to be a startup. This was kind of a moment in time where, it's like, oh my gosh, the zeitgeist was that 20-something founder that goes off and builds like a $10 billion company. And you'd be with these health plans. I'm like, I've never called ourselves a startup. So we were 3 people, and Omada was a digital health company.
Right.
You had to quickly try to, frame yourself as a measured, thoughtful business in order to have, success.
When you were raising probably from tech VCs primarily, And now there are sort of examples of tech bio VCs or health tech VCs that are sort of doing both. And actually, it's worth noting that actually A16Z's investment in Omada predates the bio fund itself. How has
it's a good statement on what you just said. Yeah.
How has the sort of investor landscape changed for you?
It's night and day different. We were the first major healthcare investment from Andreessen, but there were very few conversions funds.
Yeah.
And you'd be on the, in the healthcare kind of fund track, and they're like, well, excuse me, like, where specifically is your monopolistic IP? And it's going to be just so easy for any health plan to build software.
Mm-hmm. Right.
It's software. You just
because that's what they're known for, right?
Yeah. And you go to the tech side, and they're like, how about that budget item for that $1 million peer-reviewed study in the RCT you're thinking about running? I don't think we need that.
Right.
And so there, you'd work to kind of explain
and I think that was very much sort of in our mind for launching the bio fund, which came after the investment in Omada, that realizing that you were a tech company and there are other tech companies that happen to be in life sciences or in healthcare, but were being built like tech companies, and that was the opportunity.
Yeah, 100%.
Yeah. So any other changes that you've seen to the space? You're very much a pioneer of digital health. That's probably changed over this decade as well.
Yeah, so we talked about the investment landscape. I think, equally, you've seen drastic differences in both the go-to-market, landscape and the talent landscape.
Yeah, we should take each in turn.
Yeah. So, the go-to-market, it's very different. I think there are like more plays. There's still kind of things to be learned. I think if you use Omada as an example, we started targeting self-insured employers that can turn into business with plans. And there's a little bit of a motion now that is slightly more codified. Now, albeit it's still very difficult, very capital intensive, but it's more of a known thing. And there's been examples.
Well, so what makes it difficult?
There's a lot of stakeholders. The buying cycles are really long. You're dealing with not just, HR leaders, but consultants and their plans and their channels. And, it's a very multi-stakeholder sales process and still a risk-averse environment. But there's a little bit of like a known way to do it. Mm-hmm. And, when Omada, founded, that was far less so. You'd seen Castlight work towards selling into employers. But a little bit not the way that Omada was doing it. We figured out a way to bill through claims. We took our trials to the American Medical Association, got them to issue the first ever digital specific CPT code, just literally for billing infrastructure. Now there's many startups that have figured out on the back of that, how to bill through claims and contract, as a provider, like we talked about before. So the world has evolved. And if I could make one statement that I think is the most beneficial relative to the go-to-market is buyers better know how to buy.
So how do you make that happen?
Well, it's coming as like Omada that you're and I remember in the early days, you'd be talking to the network teams and you're like, I'm imagining a world where there's actually specific individuals on the network team focused on your digital provider network.
Wow.
And you just kind of paint this future that could be, but that's not there yet. And then you just kind of work your way to it. And a bit of it is learning together with your partners, like how do you implement, what are the claim systems? And then the next one that comes in the door, they're like, oh, we've kind of done this before. And, I remember one experience, like it was a health plan. So I get a call from a CEO of another digital health company. I was like, hey, she's like, hey, I just want to take 5 minutes to thank you. I'm like, well, why? And he's like, we just did this deal with a health plan. He kind of named it. And they sent over the papers, the contract, and they just forgot to take Omada's name out of it all. And I was like, how long did that take you to close? He's like, 3 months. I was like, well, that took us 1.5 years.
Yeah.
And what that means is, all right, there are plenty of ambitious, digitally forward people in enterprise healthcare, but like there's also like laid down processes and infrastructure and ways of buying that are pretty solidified. So it takes a little bit of time to like chip at it, morph it, heat it up, make it a little bit malleable, and then kind of lay new foundations on how to just ingest things like Omada.
Yeah, once you've retempered that steel.
That's correct. Exactly. That's right.
It's ready to go. And then you mentioned something on the talent side too.
This changes from everything, the current state to kind of the feeder world. And I remember in medical school, it was kind of like me and like 2 other people in my med school class who had an entrepreneurial bent. There was
out of like hundreds,
like 250. And it it's funny. Like I restarted the Harvard Medical School like entrepreneurship society. It had died. Like literally, it existed.
Yes.
There was only a society of 3, and then and it withered on a vine, and like so had to give it CPR and get that thing back going. And now I think that's different. It's like today's cursive is JavaScript, so you're not it's not. So there's just more tech fluidity coming out of the I think the life sciences.
Yeah. Which
speaks to more talent that can appreciate both worlds, which speaks to cultures that can build a best of both worlds together, which speaks to it just being easier to build a convergence business.
Yeah, I'd love to see this, a graph of time and the fraction of med school students who have taken a CS course.
Yeah, no, you're totally right.
Probably is just like growing dramatically.
It's growing dramatically.
Well, it's key because like if you really weren't sort of sophisticated on the tech side, you wouldn't be able to handle that side of it. It seems like at least part of the problem early on was there were just so few people that were conversant in both.
And it's funny. It's both like a vision issue that's super important, but it's also like a hiring issue.
Yeah.
You know, at the end of the day, like you need to be able to pull in incredible skill sets in your organization. And if the language you're using like doesn't communicate that you understand the skills that that person is bringing to bear.
Oh, sure.
And you can't just like, you know, over a beer, like riff on a specific thing in their world. They're not going to join. So, I mean, that's one of the reasons why the legacy health services companies have had trouble, you know, hiring talent. They'll put out a role for like, you know, IT engineer. In the language and just the appreciation of the skill sets like matter. And it's hard to get that if you're not fluent.
And the top talent are not going to want to.
They're not going to do it.
They're not going to do that.
Yeah, they're not. And the same is on the healthcare side. Like if you're just an amazing tech company, you're trying to hire great healthcare talent. They're like, they don't know.
Yes.
They don't know what they're doing.
Well, how's it going now? Like, how's it hiring sort of the latest crop, like on the ML/AI side?
Specific to that, what's neat is we have just an awesome data corpus because I mean, you know, at the end of the day, like, you know, these models are more or less commodities. It's what feeds them that's important. And Omada has operated against our users' preferences, which is asynchronous messaging, large part. So, you know, about 25 million messages that have flown back and forth between our care teams and our members, which, you know, I mean, maybe the richest, you know, data asynchronous text data corpus in metabolic care, and you know. LLMs are kind of, they came at a nice time for us.
It's a candy store for that any kid would love.
That's right. So that talent side is fine. But the neat thing relative to the last kind of couple minutes of conversation is now there's a crop of folks that have worked in tech and healthcare. Maybe they're a startup that tried to do both, but, you know, didn't work out, or maybe they're, you know, a company that has scaled and they want to, you know, do something different. So there are, there's just actually a richer, you know, crop of talent to pull from. It's no longer, you know, everyone trying to steal from Omada for people that are experienced with both. It's kind of a broader set, which is great. I think it's an amazing thing.
Oh, it's a real ecosystem. Well, so 10 years changes all of us. How have you changed?
Oh my gosh. I mean, I was extremely green when I founded Omada. I was in an MD MBA program, but hadn't done any of the business side. I didn't have any managerial experience. I didn't know what a venture capitalist was. My goal has always been each year I want to look back at last year's Sean and just feel a little bit embarrassed.
Wow. Oh, that's a really unique way to frame it.
Literally every year.
But embarrassed, is that being hard on yourself?
I mean, maybe it is, but it's the truth. Yeah. So I think I have been just a little bit embarrassed about every preceding Sean. So the Sean now is very, very different than the vintage 2011 Sean. And I mean, you know, you've been on the board a number of years. I'm sure you've seen it too.
Yeah. Yeah. Well, actually, now when I think about it after you said that, it's the thing that most people get embarrassed about is like when you watch yourself on video or when you listen to yourself. It's actually the fact it's getting embarrassed is not unusual. It's the fact that you're willing to look at that and look at it in its face. I think that really takes bravery, and most people don't do that.
The way that I think through it is to think through decisions or mistakes. Like would that have happened with today's, you know, Sean, that misstep that we made, would today's Sean have, you know, fallen into that trap? And I think I think it's a good mindset. I think similarly, you know, I always encourage entrepreneurs to, like, especially founders, try to purposely decouple yourself from the founder mind and the CEO mind.
Okay, how would you differentiate those two?
In fact, sometimes I purposely ask, like, let's just pretend I was a hired gun CEO brought in today. Oh. Like, what would I be doing differently? You know, day one, great, you know, just joined Omada, I'm the CEO. Like, what would be the next play? Yeah. And then you can similarly ask, what do you think the organization needs from its CEO, like, next year and beyond? And then that like becomes your L&D plan.
Also, organizations need sometimes things from their founders too, which are unique from what they need from their CEOs, presumably.
That's right. You could reverse it too. Reverse it too. And there have been things. I mean, you know, as the org grows, you have to, even as a founder, especially learn how to, like, work with your organization, because your teams, you know, you have so many bright people and they need to, like, find the energy around a direction, and so you have to set the strategy. But there are certain things that you know, I think is very helpful with kind of founder orientation, like that optimism, you know, doesn't always tend to, like, carry forward with scale. And if there's like new things in the market, like for us, this whole GLP-1 landscape or even the generative AI landscape, those new things, like I view it as my job to like just press the organization into seizing those.
Yeah, to really sort of almost keep that spirit that you had when you were like 10 people or 30 people, but now to do that at scale.
You do it at scale, exactly.
Yeah. Any advice you'd give to Sean, towards that? Sean? Yeah.
That's a good question. I mean, all sorts of tactical stuff.
Yeah.
My number one advice is put a ton of thought in how you price and package kind of what you're buying. That has just so much path dependency. And there's all these other tactical things.
And that sounds like a detail, but that's like the core future of your business in a sense.
Yeah, no, it's funny. It's never the strategic stuff that tends to matter as much as the tactical things.
Yeah.
And some of them you can read about, and others like it is a little on-the-job training.
Well, especially if you're creating a field, then there probably wasn't on-the-job training for digital health.
Yeah, it was newer. Yeah, exactly. Exactly.
Well, okay, so let's take us to today. So, and actually you brought up two great topics I want to hit. AI and GLPs.
Yep.
And so let's start with the AI side. So you already mentioned that Omada has this huge corpus. What's your take for how AI is going to change Omada? Where do you go with that? Where do you go from here?
Yeah, I mean, I think it's just so cool. It's the whole team and the engineering team is just giddy with it. And there's yesterday's like AI, which we've been doing, build models and ML models and recommend resources.
Almost like small ML, small AI versus a large foundation model.
Yeah, exactly. Versus kind of the generative side. I mean, there's hundreds of ideas on how to best leverage our data. So we're still learning and growing. But to give you just some specific examples right now, the one thing we launched is the ability for our care teams to just see instantly summarized views of eating history of their members. So what we found is like if they wanted to talk about food, we had a very beautifully structured like view where they could scroll through the meal patterns, looking at the eating patterns, but they were spending about 6 minutes getting the context to be able to craft a message. And so one quick hit was, have the model do that.
Right.
And then they can take that and craft it and craft a note to the member that allows them to just feel more insightful, just more precise and likely more impactful and more efficient. It's like everybody wins in that world.
Maybe even more empathetic sometimes.
And more, absolutely more empathetic. There's like step one for Omada, which is, all right, of these 100 ideas, what are the ones where you have high impact, low regulatory risk, because there are considerations that you need to think through here. We're trying to strike that balance of ensuring that, at the end of the day, like people feel the compassion of the Omadas.
Yeah.
Services as well as the intelligence, where you've got to have the humanness shine through. And so for us right now, we built our care team platform homegrown by scratch. So it's about helping to enable our care teams to be authentic humans, to come across that way, do it more efficiently, and per your point, in many instances with a little tee up, perhaps more empathetically.
Well, it's really interesting because you sort of alluded to the history of virtual based care, where it's like not having brick and mortar was like kind of crazy, right?
Yep.
And now that's actually, especially post-COVID, it's actually been quite routine. And actually, many of us prefer it to some degree.
Yeah.
It has its own conveniences and so on.
Yep.
Now you're almost like a different type of virtual, because now you're even like the caregivers themselves.
It can be. Yeah, that's totally true.
are virtualized.
Yeah, it's funny.
How far does that go? Are you always going to have caregivers and you're just massively scaling them? Are there take us 5 years into the future, like maybe even 10 years in the future, like how far does this go?
I mean, it's going to be balanced. I think you remember in peak COVID, it was like virtual care will do everything. And I felt like the crazy one, being like, guys, like biopsies still need to be done.
Surgeries.
Moles need to be removed. So it's, and it'll be the same truth here. There's a reason that artificial intelligence is a buzzword and artificial empathy is not.
Yeah.
And I don't think there is any substitute for just the human accountability. And in fact, I actually think that maybe in this era of AI, it may be actually become more valuable, like human time, handcrafted goods, like, proper human caregivers that may feel more valuable. In the same vein, you can leverage not just them, but tee up an augmented support, through these models in a way that I think just will transform outcomes and impact the world.
Yeah. And, we've talked about scaling, and we're talking about the 1 million members. Maybe this is how you get there.
Yeah.
Get beyond there.
It helps. Yeah.
Okay. It's such a crazy time because we've got AI doing this insane thing. And then generally unrelated to AI, but very related to Omada is GLP-1s.
Yeah.
Like, how does that play into what you're doing at Omada?
Yeah, I just feel giddy with what's happening here, because you've got this two parallel tracks, like just extraordinary technology innovation. extraordinary life sciences innovation, like two different silos. And I mean, similar to like the fact that you're a convergence investor, Omada's a convergence company, they just hit each other.
Yeah.
Like right now, right at the moment. And I think they're both, really have knocked on the doors, of Omada as a scaled provider that, has not only the data for the generative AI side, but also just enough scale and enough clinical credibility to capture the opportunity in GLP-1s. The way I look at them is incredible. I mean, incredible breakthrough. Like, humanity, we should pat ourselves on the back that these exist.
Yes.
In large part, especially since the data has borne out in type 2 diabetes, I think they'll, generally consider it a very safe medicine, and hopefully that continues to be the viewpoint. The challenge is GLPs are great at quantity. You can and will lose weight on a GLP without changing anything about the quality of your calories, because it will reduce the quantity.
Right.
So,
you just will lose appetite.
That's right. You'll lose appetite. So you're dropping your caloric intake, but eating exactly the same foods. The challenge with that is most patients tend to not want to be on these medicines for life, even though, you will find the KOLs that argue that that's the right clinical point of view. Right now, that's counter to the patient preference. And then the cost profile is making that for the employers that are covering GLPs for obesity, a challenge as well. There are very few that, are thinking, well, shoot, I'll cover this for life. So you have this issue where, okay, you've got quantity. Well, what does the quality? And that's where Omada thinks we can really differentiate. If GLPs are quantity,
right,
Omada's quality, because you can use these as almost a behavioral catalyst, help reframe someone's psychology around, hey, I can lose weight. This is amazing. And then on that, you're like, well, what are your goals relative to the medicines? They're like,
let's do it in a healthy way.
Exactly. Well, let's take advantage of this therapeutic window.
Yeah.
Like, let's figure out some new meals that you can just start to incorporate. Great, you're losing weight. What are some new activities that you could do now, that you couldn't do otherwise? And then Omada can address some of the clinical, complexities here. I mean, I think that the next issue that is already starting to bubble up is sarcopenia. I mean, because what's happening with these meds, you'll lose fat and muscle mass. If you do regain, you're going to regain only fat. So there's all these complex body comp questions that are going to require new, physical activity protocols on top, and recommendations and diet and intake to make sure that, that you're addressing this kind of truth about weight loss generally, not specific to the GLP-1s.
Yeah, especially if your body muscle mass goes down, then your basal metabolic rate goes down.
It makes it more likely you'll regain. You'll feel hungry. Yeah. Exactly.
Yeah.
So,
and if you're only eating, I don't know, 1,500 calories, 1,000 calories with these things, whatever small number it is, then every calorie counts, right?
Exactly. Omada's made some decisions we're happy about. The first is to launch this GLP-1 care track.
Yeah.
And then we've chosen to not initiate people on the medicines, but just, support them regardless of where the script came from.
Yeah.
So when we work with our partners who are covering GLPs for obesity, it's like, you can create kind of a little bit of an all roads lead to Omada strategy where look for these to be covered. We want to make sure that you have the lifestyle support alongside.
Yeah, that makes sense. So yeah, I mean, given all this that's going on, where do you think this gets us to? What does digital health look like, 5-10 years from now?
Well, yeah, I mean, for Omada, I hope these innovations help us do what always has kind of been the most important, which is to have tomorrow's, epidemiologists notice bend in disease curve and have us be a part in that. It's been this weird kind of thing where I feel like every couple of years you see this report on, diabetes measures, et cetera. And you're like, wow, the nation's gone nowhere.
Was that really true? Have we really gone nowhere, or have we gone worse than nowhere?
In fact, if anything's gone in a worse direction. We're on a poor trajectory as a country, to say the least. So, I think these innovations help us hit a level of scale that matters. And this is the most acute labor crisis we ever had in the U.S.
On the provider side.
On the provider side, you talk to the average provider and the C-suite. Well, what are your challenges? They list 10, 1 through 8. Or labor. There are not, we don't have enough practitioners.
So not enough doctors and not enough nurses.
Yeah, none. And I mean, we're not going to have 200,000, primary care clinicians show up on a tanker. So, so that what does that mean? A, even outside of what we do, you have to find technologies that give more leverage to every credential, like inter-LLMs. B, what you need is to provide care differently. There is no way that a decade from now, the primary care clinician is going to be point on something like longitudinal diabetes care. So Omada can come in as a between visit care provider, as an adjunct to primary care and a partner, and make it such that, really what you need to do is route the person to us, and we'll handle that between visit care and take that off your plate, which I think is going to be required.
Yeah, I mean, it's amazing that scaling goes from an aspiration almost to an obligation.
There is a silver lining. I mean, this is just an extraordinary crisis, of labor. What is happening is the everyday provider recognizes that there's not a solve. And I mean, you've had providers that like literally they're like, well, shoot, we've tried almost everything. They bought nursing schools.
Right.
Like, gobbled up nursing schools to try to, build, but there's nothing that's going to be enough. So it's like, we have to deliver care differently. Right. What does that look like? Who do we work with to do it?
Right. And then, so the shortage is one thing. Then the other sort of crisis that we all know about is cost.
Yeah.
So presumably this plays into that as well.
Oh my gosh, if we just kept the percent of our GDP spent on healthcare constant, but just used the dollars better, like we've got an embarrassment of riches to put forward, to the country here relative to the it's not like, oh, could it be done more effectively or efficiently? Like, look anywhere besides, the U.S. and you find ways that one could. So, but you kind of need a rock thrown into the lake.
Yeah.
And there are enough like pressure points there that I do think that the silver lining will be it's kind of hit the fulcrum where it's reinventing the system.
Well, so let's paint the picture. So like you're dealing with something which is one of the biggest crises: prediabetes, type 2 diabetes, weight, and its comorbidities, hypertension, all musculoskeletal, all the comorbidities. So the problem is very clear. And then on top of that, you have the provider problem and the cost problem.
Yep.
You put in AI and GLPs, it's almost like this wonderful, almost Deus Ex Machina, like to the rescue.
And no technology to the rescue. It's literally, I'm like, in absence of that, plus like, the Omada layers to tie the room together.
Yeah.
What happens? It's, you know what I mean? It's like,
but then, then what keeps us from the future we're describing? Like what's in our way?
I think it's coming. I genuinely do. I feel more optimistic, than ever. In general, I don't think there's an overnight success. I think that's especially true.
Yeah.
In healthcare and building a healthcare business, but I think it's coming. I mean,
well, what do you think about regulations in this space?
I mean, that's one of the reasons why it takes a little bit longer.
But especially, let's say, additional regulations for AI. Do you see a role for that?
Right now, the general basis on how to use generative AI says, like, look, guide a licensed practitioner. So, we're at that world where it's like, use self-driving as an analogy, like it's driver assisted, like you can turn it on, but you got to touch the wheel.
Well, and there's already Dr. Google in play. And so this is amplifying that.
Yeah, exactly.
And practitioners have regulatory bodies that govern their work and so on.
I think there will be ways to, create kind of targeted, regulatory like pathways for hyper-specific things that have low patient risk.
Yeah.
And I think
no other obstacles. It feels like the way you're talking, it feels like it's inevitable.
Again, I mean, it speaks to the three things that have changed. What needs to happen for an innovation ecosystem to flourish in a way that wasn't there before? You need new capital partners. There's more folks that understand tech and healthcare, and there's some proof points that you can make money here. I mean, you need that to create kind of a healthy capital environment. And then secondly, you need like more go-to-market motion models that make it just a little bit easier for the next person. Right, and that's critical. And then you need the people.
Yeah.
And so, I think you've got the three of those. You've got macro pressures that are requiring innovation is not a vitamin, it's a painkiller, at this point. So I'm very optimistic. I think we're still at the beginning. I think the next 2 decades are just going to be extraordinary, and we need to make it happen.
Well, it's amazing because not only have you co-founded Omada, you basically helped co-found this whole ecosystem, right? I mean, that's what needed to be done.
Very, very generous, and thank you for being a partner, and Andreessen for being a partner along the way.
Oh no, it was our pleasure. Obviously, you think a ton about healthcare. Like, what do you do for your health?
So I have 2 kids. I have a 4-year-old and a 2-year-old. A gym called Lifetime opened up near my home, and I begged I would have paid any price to sign up because they have childcare for 2.5 hours.
Oh, wow. It's a deal you can't refuse. offer you can't refuse.
So we've been joking, I'm going to be the best shape of my life because, you're busy as an entrepreneur and childcare is so precious and the kids love it. So we call it the Family Fun Center.
Excellent.
Not Lifetime Gym, but I got a push notification from Lifetime that said like, congratulations on your 25th visit.
Oh, wow.
And I looked up how long it had been open. It was like 45 days.
That's excellent. Excellent.
It's funny. I try to be like, similar to Omada. Omada's pragmatic relative to, what fits into your world and what best kind of, fits into your life, and tend to not be overly zealous one way or the other, but just try to, abide by healthy food habits.
That makes sense. Well, thank you so much for joining us on Raising Health.
Thank you for allowing me to be the first guest on this new instantiation.
Oh, thank you.
All right. Take care, Vijay.